Welcome to Think Like a Nurse, the video outreach of KeithRN. Today's topic, getting to know Keith of KeithRN. It has been shown that learning is promoted when there is a relationship or a connection established between the educator and the learners. And it is my objective today just to share a bit about myself and for you to establish in some small way that connection with myself and the work that I'm doing with KeithRN. That is a rich resource that's committed to transform nursing education through the use of clinical reasoning case studies. Though there will be obvious similarities and differences between you and me, but as educators I know we have in common a passion for promoting the learning of our students. Like most of you in nursing education, I too am grounded and established in clinical practice. I've been blessed to serve as an RN for 30 years and I've worked most recently full-time in cardiac telemetry, cardiac intensive care, and the emergency department. I currently work in the critical care float pool of a large metro hospital here in Minneapolis, where I work primarily between the ED, Med-Surg Neuro ICU, cardiac medical ICU, cardiac surgical ICU, cardiac telemetry, and even circulate as a rapid response team as needed. Like many of you too, I'm new to nursing education, having taught just a few years as a clinical adjunct and only 2 years full-time in the classroom. But my journey in nursing education began on a medical mission trip to Honduras, Central America, 9 years ago. Our team served at a mission hospital in a rural, underserved community. They had multiple physicians and a surgeon, but no one to deliver anesthesia on a full-time basis. Only if a medical team came to serve and had a CRNA did they have the ability to do major surgery. So I was helping and serving in the OR and there was no anesthetist available. And so as the nurse I was titrating ketamine as an IV push for the surgeon could do this abdominal hernia repair on a small child. Now, as most of you may know, ketamine is a conscious sedation agent. It is not meant to be used only as the primary anesthetic for surgery. And as this child was at times squirming as it began to lighten up, I just was so uncomfortable with some of the disparities that I had seen in the developing world with the quality of medical care, but yet doing the best they could, that I wanted to do something about that. And so I currently had ICU experience at that time, but only had a 2-year degree. And so I enrolled at a local BSN completion program and completed my BSN to springboard into anesthesia school. I completed my degree, shadowed a nurse anesthetist, and realized that I really did not enjoy what that practice involved. To me, I was literally bored at the end of the day as I observed what a nurse anesthetist did in practice. But at that time, I was also reading a book by Christian author John Eldredge that was titled Wild at Heart. And this quote literally jumped off the page. He says this, "Don't ask yourself what the world needs. Ask yourself what makes you come alive. And do that, because what the world needs is people who have come fully alive." And this quote gave me permission to pursue what I believe is my God-given passion and talent in nursing, the ability to teach. I realized how much I enjoyed precepting at that time new nurses in the emergency department and how I enjoyed seeing the lights of learning come on with these new nurses that I was working with. So after I completed my BSN, I decided to go straight to my master's in nursing education instead of nurse anesthesia. And I've not looked back ever since. So then the question is, how did I become such a strong advocate of clinical reasoning? Well, just recently in my 2nd year of classroom teaching in 2010, I felt such a strong disconnect and was dissatisfied and discouraged between what I saw with the traditional content-heavy lectures that I was doing in the classroom, the NANDA-driven care plans, and what I knew was needed and relevant for students as a still practicing nurse who was straddling both domains of education and clinical practice. I was torn at times between how I thought as a practicing nurse at the bedside to prioritize care and what I was teaching to my students. I did not feel they were getting the needed content and concepts to think like a nurse in practice. Well, everything changed for me when I read Patricia Benner's latest work, Educating Nurses, a call for radical transformation, and her co-authors over the winter break of 2010 to 2011. This book, as you know, is based on the Carnegie Foundation educational research, identifying that nursing education needed to be transformed by such radical and unthinkable proposals, such as decreasing our classroom theory content. Instead, emphasize needed concepts. Contextualize all of our content and concepts to the bedside where it matters most. Integrate the classroom in the clinical domains of education and emphasize clinical reasoning, which is the ability of the nurse to think in action and reason as the situation changes, capturing trends in vital signs assessment and vital sign data. In a nutshell, all that is taught in the classroom must translate to the bedside. This captured so concisely what I was feeling and put in writing what needed to be done, and emphasized that I then spent the last half of my winter break reworking my assigned theory content so that my lectures would incorporate and apply these paradigm changes in my classroom. I had all of the cardiac content that semester, and I situated my 4 content lectures on Mr. Kelly, a middle-aged, overweight man who developed in Lecture 1 atherosclerosis and hypertension, and in Lecture 2 over time progressed to an acute MI. In Lecture 3 he developed heart failure, and in Lecture 4 years later developed PAD and PVD. I cut my lecture content in half by emphasizing concepts and used the other half to situate student learning through a clinical reasoning case study based on Lisa Day's paradigm example from Educating Nurses that required the students to identify and pick out what was relevant and establish the nursing priorities and interventions with a clinical scenario from that concept of clinical reasoning. Well, after I modified it and adapted Lisa Day's paradigm example from Educating Nurses at the end of the semester, I did a simple survey with my classroom. Student response afterwards was so overwhelmingly positive. Not one student said to go back to a traditional content lecture, but instead continue this emphasis on concepts and clinical reasoning. One student summed it up for many. She said this: "These clinical reasoning case studies were very helpful. I didn't feel like I was memorizing for the test. I felt like I was able to apply the information, and it helped put knowledge into practice and made it clear why it was relevant." In closing, an ancient Chinese proverb states that a journey of 1,000 miles begins with a single step. I would encourage any nurse educator that you too can take this needed first step and be the change in your program, using clinical reasoning to promote needed nurse thinking and better prepare your students for bedside practice. Together, we can realize Benner's transforming vision of nursing education to not only promote the learning of our students, but more importantly, better outcomes for the patients they care for. Thank you.